All right, we've got a good number of people here to start with, and more will come, I'm sure, as we keep going. But we'll welcome everyone to Pediatric Teaching. And this is the third of a series of talks on heart disease in children, so pediatric cardiology. And I know you get lots of teaching on pediatric cardiology as you go, but these are what I wanted to try to talk about were the basics, the essentials of common presentations of children with heart disease and heart failure. And the first week we talked about ECGs and how to read a pediatric ECG. And then the next week we talked about, this was last week, we talked about left to right shunts and how they are probably the most common reason why infants and children, but particularly infants, present with heart failure. Acyanotic heart disease. So we talked about ventricular septal defects and atrial septal defects and patent ductus arteriosus and AV septal defects. We talked mostly about that. And if you remember, we talked about three common presentations. The first one being the commonest of an infant who presents with what looks like bronchiolitis, which looks like a bit of pulmonary congestion and excuse me, that just it's okay. Just hold on 1 second and I'll be back. Where's that, Daniel? Where's that? Okay. Okay, sorry. Yeah, so the second week we talked, last week we talked about left to right shunts and how that's the most common cause of presentation, really, of children who present with what looks like an acute lower respiratory tract infection, but they end up having a murmur and they have clinical signs of heart failure and have a big heart on their chest x-ray. And so that's the most common probably presentation of congenital heart disease. And then, but I also raised two other scenarios, and I just want to go through them this week, the other two scenarios. But to start with, I want to remind you about a couple of things, a couple of principles that we talked about last week. And one was when we see a child who might have heart failure, then we need to think, what are the clinical signs and what do they mean? And remember we said last week that you can separate heart failure signs into those that are general signs of heart failure, such as tachycardia and tachypnea and sweating with feeding and failure to thrive. Like babies who have heart failure often present like that, don't they? Failure to thrive, they're sweaty when they're feeding, they're tachycardic and tachypneic. You can also classify the sort of heart failure into those signs that suggest both either right or left congestive heart failure. So when we see hepatomegaly in heart failure, a big liver, that's because of right-sided congestive heart failure. And when we see generalized edema, that's also because of right-sided heart failure. Or we might see raised jugular veins, the same thing, right-sided congestive heart failure. But when we hear crepitations in the chest and when we hear when a child's got effusions, that's left-sided congestive heart failure. It means their left ventricle is failing. But often it's a combination of both things, isn't it? We see, clinical signs of heart failure indicating both right and left ventricular failure and also general signs. And I just think it's useful to describe children in that way. So then we can say whether the child's predominantly got right-sided heart failure or left-sided heart failure or biventricular heart failure. And then there's the other type of heart failure, which is where children have low output heart failure. So one is congestive heart failure and the other one is low output heart failure. And sometimes children who've got if it's mild, they might just have tachycardia, tachypnea and sweating and maybe failure to thrive. If it gets worse, they have these signs of congestive heart failure. And then sometimes if it gets much worse, then they have signs of low output heart failure, hypotension, weak pulses, a narrow pulse pressure with low volume pulses, they may have cold peripheries or skin mottling, or they may stop passing urine. So they're signs of low output heart failure, which is for some types of heart failure, that can be the first presenting feature. But most types of heart failure, they get congestive heart failure first, and then sometimes they get low output heart failure. And when you see a child with heart failure, it's useful to be able to describe these signs because it can indicate whether the child's got mild, moderate, or severe heart failure. Okay, I hope that makes sense based on what we talked about last week. Last week, we also touched on just overall the different causes of heart failure, from those that are structural congenital heart failure, like acyanotic heart failure. We talked about last week about VSDs, ASDs, PDAs, and then cyanotic heart disease, which we haven't talked about yet. And then conditions that are where there's a problem with the heart valves, like rheumatic heart disease, where the valves are inflamed or damaged, or congenital valvular anomalies, where a child might be born with an abnormal mitral valve or an abnormal aortic valve. And then there's the problems of the heart muscle itself, and that can be either congenital or acquired. And if it's congenital, it's often considered a cardiomyopathy. And if it's acquired, it's often relates to myocarditis, an inflammation of the muscle related to a virus infection. And then there's the cardiac conduction pathways like arrhythmias. So some children who present with arrhythmias, supraventricular tachycardia, or the things we talked about in the first week of the cardiology series, they can present in heart failure. And then if you think about the other structures of the heart, the pericardium can also be involved and can cause heart failure if you've got pericardial tamponade or a big pericardial effusion. And then heart failure can be secondary to lung failure, so respiratory failure, cor pulmonale, and it occasionally can be secondary to high output cardiac failure, which is a rare condition. But if you think about the causes of heart failure being all of these things, then you won't miss a cause of heart failure. But again, it's useful to think about the types of heart failure that can occur at different ages. And in the first week or last week, we talked about VSDs and the typical age that they present. I wanted today talk about two different age groups and when they present. And the first one is the newborn baby who presents in heart failure, and what that is often caused by. Last week I talked about three case scenarios, and I just want to go back over the second one. And the second one was a 5-day-old baby who presents with poor feeding and shock. This is, again, the case scenario is a newborn who's well at birth, has normal APGARs, goes home day 2 or day 3, seems to be okay, is a term baby, there seems to be no problem, and then they become lethargic and they have fast breathing, they're not feeding, and then they go into shock fairly rapidly over a space of hours often, and they're peripherally cyanosed, often with cold, pale limbs, and their pulses are difficult to feel. And this was an X-ray of such a child who presented exactly like this, 5-day-old, seemingly well, went home, and then comes back collapsed. So it's the collapsed newborn baby. It could be 5 days of age. It could be even 5 weeks of age. This particular case scenario. When we think about the newborn baby who presents in shock, there's a number of different causes for that, and it's useful to understand what the cardiac and the non-cardiac causes are. So if we see this clinical scenario, we'll be able to think, well, this could be a cardiac disease, or it could be something else. But they all present in roughly the same way. They all present lethargic, can't feed, they're pale, mottled, cyanosed often, they're tachypneic, and they have cold limbs. They often have poor or absent femoral pulses, peripheral pulses. They sometimes have a metabolic acidosis often, and they won't be passing urine. And this case scenario, if a baby is well at birth, discharged at home, and then returns in shock in a few days' time, can really only be one of 4 things. And the first 2 are the most common. A baby could have severe sepsis. I guess again, a bit less likely because they're apparently well at birth. There was no risk factors for sepsis, but still the baby goes into shock on day 5 or day 10, just sometime in the newborn period. It could be sepsis for sure, number one, or it could be some form of congenital heart disease where there is an obstruction to the left ventricular outflow tract. So that means an obstruction at the aorta or at the aortic valve, or the left ventricle itself, something like a coarctation of the aorta or aortic stenosis. And the reason why they're well at birth is because they have adequate systemic blood flow through their duct. And it's only when their duct closes that you get hypoperfusion, where you get shock with an absence of blood flow or much reduced blood flow to the systemic circulation in the peripheries. So those are the two most common reasons why a newborn baby may have been well at birth, they go home and they come back because of some congenital heart disease, like a coarctation, also perhaps like a transposition of the great arteries, or the baby's got sepsis. And of course, sepsis can occur at any time, at any age. Early or late onset neonatal sepsis is very common. Usually there's some risk factors for the sepsis, but not always. And then there's a couple of other less common things, less common conditions that may cause a newborn baby to go into shock after having been well and at the time of birth. And one is an inborn error of metabolism, some metabolic disorder, such as having a very high ammonia that can cause babies to go into shock. And often that occurs after, in these rare cases, it'll occur after a baby starts to feed. So they go home, they seem to be well, they're feeding, and because they have in milk feeds, there's protein, they can't process the protein, so they develop a very high ammonia level, and that can cause them to go into shock. So this is the third one is a very rare event, but it does occur, and it's part of the differential diagnosis of the newborn baby who presents in shock. And the fourth one is, the baby's gone home and for some reason has had some asphyxial event, like a sudden unexpected death in infancy, or they presented with a near miss SIDS where they've been asphyxiated, or they've had poor sleeping arrangements, and they've had a lack of oxygen during sleep. So that sort of SIDS presentation is very similar to this. But if you see a baby who falls into this category, think of sepsis. Could it be sepsis? Could it be congenital heart disease? Could it be the baby's had an asphyxial event at home? Or could it be some metabolic condition? They're the four things. This baby that I just showed you had left ventricular outflow tract obstruction, and she had what's called an interrupted aortic arch. And it's like having a severe coarctation. You can see the aorta comes up here, and of course it should go down here, shouldn't it? It should go to the rest of the body, but no, it is obstructed or interrupted. And this is a rare condition, but when you think about coarctation of the aorta, interrupted aortic arch, an aortic valve stenosis, like critical aortic stenosis, or a hypoplastic left ventricle, or a mitral valve, which is too narrow, all of those things can lead to the same presentation. That is, when the duct closes, they don't have adequate systemic blood flow. It could be anything from involving the aortic valve to the aorta itself or the left ventricle. And it just happened that this baby that I showed you had an interrupted aortic arch, just like I've drawn here. So that's the presentation. But remember, just if you see a baby like that, think, could it be sepsis? Could it be congenital heart disease? Could it be an asphyxial event, and you take a history of that and consider that? Or could it be some inborn error of metabolism? They're the only four things. If you see a baby who's shocked, I always think it's like there's a sort of golden hour to do something. And of course, if you've got a baby who's got some forms of severe congenital heart disease, sometimes there's not much you can do. But if they've got sepsis, then there's sometimes a lot you can do. And the main thing is to try to do most of these things in quite a short period of time, in the first hour after you see them. And that typically involves many of these things. Now, not all these things are available, but you can give oxygen, you can give a bolus of fluid, you can give antibiotics, so benzoyl penicillin, gentamicin, maybe some flucloxacillin if you're worried the child's got staph sepsis. And maybe you can give some dopamine or dobutamine as a way to improve their heart function if they've got sepsis or if they've got congenital heart disease. So there are things you can do even if you don't have this one, prostaglandin, alprostadil, is a way of opening up the duct again. And that can help these babies that have got an interrupted aortic arch or coarctation or aortic stenosis. That's something that's sometimes done in babies with that problem, but the most common presentation is a baby collapses like this with sepsis or with some form of congenital heart disease, and you can help this baby if they've got severe sepsis and try to support them if they've got congenital heart disease. So that's the baby who I said there's three common presentations of heart failure. One is the common one of an infant who presents with a VSD at 4 to 6 months of age, and they present with what looks like a bronchiolitis-like illness or recurrent respiratory infections, and you find you've got a VSD. You find that on echo or on auscultation. The second one is the newborn baby who presents in shock, and the type of congenital heart disease they have. And the third type of presentation that's quite common is that of an older child, often a school-age child. So this was a 12-year-old boy. This X-ray is a 12-year-old boy who presented with fever and palpitations and difficult breathing over about a week or two. He'd been sick for just a bit longer than a week, this boy. And he noticed himself, he's 12, and he'd noticed himself that his heart was beating very fast. He could feel it. And he had fever, and he was very unwell, and he was getting progressively more short of breath. On presentation, he had tachycardia. His pulse was very irregular in rate and volume. You could feel that irregularity of his pulse just to palpate his radial pulse. His apex beat was prominent and palpable in the 6th left intercostal space in the mid-axillary line. So you know that already on clinical grounds that he's got cardiomegaly, and he had crepitations in both lung fields, and even on air, he had an oxygen saturation that was just 92%. So he wasn't very hypoxic, but he was a bit hypoxic, and he looked quite pale. This was this boy's chest X-ray, and I think you can see that his heart is large, and he's got, I hope you can see, he's got bilateral pleural effusions, and it looks like severe heart failure. Can anyone suggest what might be wrong with this boy? This is a boy who was previously quite well, and then he presents like this. What could be going on? Okay, well, again, going back to those scenarios that I talked about, the first one, the newborn, or the infant with a VSD, the neonate who presents in shock, and this older boy who presents with heart failure after being previously well, could be one of a number of things. Now, I guess the first and most likely thing is that he could have rheumatic heart disease, couldn't he? This could be rheumatic heart disease, and he might have rheumatic heart disease, but he might also, when children have rheumatic heart disease and they're in heart failure, often we don't detect, but we should try to detect whether or not they've got an arrhythmia as well, because rheumatic heart disease affects the myocardium, the heart muscle, and when inflammation affects the heart muscle, that can sometimes lead to arrhythmias. It also affects the muscle in several ways. One is it causes the heart muscle to stretch a bit. And when you stretch the atrium, sometimes you can get an atrial tachyarrhythmia, like an atrial fibrillation. And so many of these children, when they go into heart failure, if they miss their heart failure medications, or they have another episode of rheumatic fever, then their heart fails a bit, their atria stretches because they've got high end diastolic pressures, so their atrium stretches, and when the atrium stretches, then that affects their cardiac conduction fibers in the atrium, and that can lead to atrial fibrillation or to supraventricular tachycardia. So it's quite a common scenario for children with rheumatic heart disease to present with atrial fibrillation and to present in heart failure with bilateral pleural effusions. I think this is that's probably, based on what's common, would be the most likely scenario. But there's a couple of other things that could be happening. One is the child might have myocarditis, and children with myocarditis sometimes have a prodromal illness where they've had some diarrhea or they've had a respiratory infection, and then they may have muscle aches and pains because they might have a flu, and then they come down with heart failure like this. So this would be the clinical scenario of a 12-year-old boy who presents with acute viral myocarditis. Could be exactly the same. And if you've got myocarditis, then you can have inflammation or irritation of the heart muscles, so therefore you could be in atrial fibrillation as well. And the third possible reason that is, I guess, equally likely is that he might just have a congenital form of atrial fibrillation that hasn't affected him up until now, and he's gone into atrial tachyarrhythmia, and that's led to him having heart failure. So they're the three most likely reasons why a 12-year-old boy who's been previously well might go into heart failure: rheumatic, myocardial, like myocarditis, or maybe some underlying tachyarrhythmia. And I think it's important to be thinking about these types of case scenarios because, as I said, much of pediatric cardiology is about pattern recognition. And if you can recognize that's the differential diagnosis of a 12-year-old boy who presents in heart failure, then you can make the diagnosis, right? If you can put these different clinical scenarios into categories. So the newborn who presents with shock, the infant who presents with a murmur and recurrent respiratory infection, or the 8 or 10 or 12-year-old boy or child who presents with heart failure. So when we think about the heart failure in the older child, again, rheumatic heart disease is the most important and the most common. And those children, of course, have the other features of rheumatic heart disease. Not always, but you need to go through the Jones criteria and see if they've got joint pains or sore throat or ECG changes, etc. The second one is myocarditis, and they won't always have diarrhea, but they usually have some pre-existing viral infection. For a week or two, they might have had a respiratory viral infection, and then they get worse with respiratory distress and heart failure. That's the common situation. And then, as I said before, like pericardial disease, we see a lot of staph pericarditis, and that this child that I've just shown you, it could be staphylococcal pericarditis. This boy might have a pericardial effusion with bilateral pleural effusions, and that might be why he's in heart failure. High fever, tachycardia, it could be pericardial in nature, right? Or arrhythmias. You might have an underlying congenital form of SVT, like Wolff-Parkinson-White syndrome, and he's just gone into SVT for the first time in his life. That happens to children of 5 years or 8 years or 10 or 12 years. It can happen. And the last one is that I've seen a child who looks just like this, with an X-ray looking just like this, with severe anemia. And if he's developed severe anemia, like the child I'm talking about had a hemoglobin of 1.6 grams per deciliter, very, very low hemoglobin. And children can have severe heart failure like this if they've got a severely low hemoglobin. So the combination of severe anemia can lead to severe heart failure. So when you see an older child beyond infancy who has these features of heart failure, then think about these things, especially the school-age child. Could it be rheumatic? Could it be myocarditis? Could it be pericardial disease like staph pericarditis or TB or a virus with myocarditis? Or could it be an intrinsic arrhythmia? Or could the child just be pale because he has severe anemia? That's the main thing I wanted to explain. The treatment. Now, I wanted to talk a bit about the treatment of heart failure today. And first of all, say that heart failure is not a diagnosis. Heart failure is just like a clinical syndrome, like respiratory failure. We don't see respiratory failure as being a diagnosis. It's simply a clinical syndrome, and we have to identify what the underlying cause is. And we've talked a lot in these last 2 weeks, these lectures, about the underlying cause of heart failure. And sometimes children have two things. They have an underlying cause, and then they also have something that triggers their heart failure. Their underlying cause might be that they've got a ventricular septal defect, but why are they in heart failure right now? Well, they're in heart failure right now because they've got a respiratory infection or because they've developed anemia, and that might be why the child with the VSD went into heart failure. Or similarly, with the child who's got rheumatic heart disease, we've got to think, why are they going into heart failure now? It might be that they've gone into atrial fibrillation, or maybe they missed their medications, or maybe they've got electrolyte imbalance and they've, their arrhythmias because of that, or their myocardium is not functioning well because of that. So always think about, is there something else beyond the underlying cause of their heart failure that's exacerbating their heart failure, that's a trigger for going into heart failure or worsening heart failure now? So when we're treating heart failure, we need to identify the underlying diagnosis and the conditions that exacerbate the heart failure, and then use your clinical skills to assess and describe the severity of the heart failure. Remember, I described before the features of left and right congestive heart failure, or biventricular congestive heart failure. And I described the features of low cardiac output, which is the more advanced form of heart failure. So that makes it very severe. And if you can describe that, then it can help you, first of all, understand whether the child's improving with medications. It can also help you determine how intense your therapy has to be at the start. And so if they've only got mild right ventricular failure, or mild left ventricular failure with crepitations and nothing else, no edema, no severe congestion, no hepatomegaly, then maybe they'll get by with just a small amount of diuretics and cutting back on their fluids, for example, reducing their salt intake. But if they've got severe heart failure with low cardiac output, or severe biventricular congestive heart failure with generalized edema, then they're going to need a much more intensive therapy to begin with. And so assessing and describing the severity of heart failure helps us calibrate the treatment that we are giving to a child who's got heart failure. So part of that is to quantify their degree of edema, so to know how much edema they've got. And you can do that when I say quantify their degree of edema. I mean, you can describe... Recording in progress. You can describe... if you... To quantify their edema, you can describe how much edema they have. Is it just of their feet, or does it go up their calves and edema to their knees or above? Do they have an edematous face? Can they open their eyes? You need to describe their edema, both in terms of their peripheral edema, their degree of lung edema, facial edema, etc. That's you should describe that, because it helps you monitor how well they're going as well. And then also assess their end organ function. If your heart's not functioning well and you have and if the child's got low output heart failure, then they may have impaired kidney function or reduced urine output. And again, it's a matter of describing the severity of their heart failure. Is it mild congestive heart failure? Is it moderate congestive heart failure? Is it severe congestive heart failure? Is there low cardiac output or shock? That's how you can classify heart failure. when you're treating heart failure, do the basic things first. So salt and water restriction is important, and certainly I see children that are on treatment with diuretics, but we've still got an IV drip in and we're giving them maintenance fluids. Now that makes no sense at all. We have to, in children who have heart failure in whom you're giving diuretics, don't give them intravenous fluids. There's no point in that. Just salt and water restriction and give them diuretics. So I usually start with 0.5 milligram per kilogram twice a day, but even go up to 1 milligram per kilogram 4 times a day intravenously, and sometimes even more. So the minimum might be 0.5 milligram per kilogram twice a day orally, and a maximum might be 1 milligram per kilogram 4 times a day intravenously. But sometimes at the start, in the first 24 hours, they may need even more than that to get their to start relieving them of the edema that's causing their severe congestive heart failure. And so sometimes you'll even go higher than 1 per kilo QID, but it depends on how severe the heart failure is. It depends on whether or not the child's been on furosemide before. It depends on what their renal function is like, because you don't want to give them an excessive amount if their renal function is not good. So you can calibrate the amount of furosemide to the severity of their heart failure and adjust it. What they get in the first 24 hours is not necessarily what they'll get in the next 24 hours or a couple of days later. So that's reducing afterload by reducing their intravenous fluid or their fluid intake, and also giving diuretics. And you can give spironolactone as well, like a potassium sparing diuretic. So usually 1/4 to 1/2 or 1 tablet, depending on their size. 6.25, 12.5, 25 milligrams twice a day when they're tolerating enteral feeding. When you're thinking about after preload reduction, so preload, I've got this wrong. So afterload reduction is using an ACE inhibitor like a captopril or an enalapril. Afterload reduction. Now that reduces systemic afterload, which means that the heart doesn't have to do so much work. If you can give captopril or enalapril, the heart doesn't have to pump against such high levels of afterload resistance. And the question you need to ask is whether or not captopril or enalapril will be safe in this particular patient. Is it safe in this patient? And it's usually safe if they have a normal blood pressure and they have adequate renal function. It's not safe if they are hypotensive. Right? So don't give it if the child's got especially diastolic hypotension or they've got severe kidney impairment. But if they've got a normal blood pressure, then it's usually safe. The third, so we've talked about preload reduction with diuretics. We've talked about afterload reduction with systemic vasodilators like captopril and enalapril. And then the third thing that sometimes is done is to give some medications to improve contractility. And it used to be that we'd give digoxin to many patients with heart failure. That's been shown in trials in the last 5 years to probably not be useful for most children in heart failure because it has some toxicity. There's a good trial in children who've got rheumatic heart disease to show that it's only useful in children who have atrial fibrillation and rheumatic heart disease. So I don't give digoxin to other children with heart failure unless they've got atrial fibrillation or they've got extreme tachycardia, because it can cause some toxicity, especially if you've got electrolyte impairment. It can also cause some ECG changes that are not favourable to children. So if a child's got atrial fibrillation and rheumatic heart disease, or atrial fibrillation and some other cause of heart failure, then it's a good idea to give digoxin. Otherwise, I think diuretics and afterload reduction is probably the best thing. You should try to correct anemia. If the child's in heart failure, they'll often be better with the hemoglobin that's a bit higher. So our normal thresholds for transfusion which might be a hemoglobin of 7 or 6, they don't really apply to children, generally speaking, in heart failure. But remember that you've got to correct, if you've got a child in heart failure, excuse me. I'll get that in a minute. You should also try to control fever, and children with heart failure and fever will have an increase in their cardiac work. That is, when a child's got a fever, their metabolic rate increases, and their heart will have to do more work. So it's best if you can control their fever to bring their temperature back to normal. If they've got an underlying infection, then you need to treat that. And if they've got electrolyte abnormalities, children in heart failure often have abnormalities of their potassium, their sodium, their magnesium, and their calcium. And particularly potassium, magnesium, and calcium can lead to a worsening of heart function if those electrolytes are low. And this is very important, especially if they're on diuretics. They'll often be losing potassium, magnesium, and calcium, and sodium. And all of these things can lead to their heart failure being worse. So we need to correct that. This is an ECG of a child I recently saw in heart failure. And we looked at ECGs in the first week, but I hope you can see that there's something abnormal about this ECG. And if we went through it, the PR interval looks fairly normal, 1, 2, 3, 4, maybe 5 small squares. There's upright P waves in lead 1 and AVF. You can see it there. So it looks like it's in sinus rhythm, although the PR interval is a little bit long. The QRS complex looks normal. There's only 2 small squares between it. There's no widening of the QRS complex. The voltage criteria, not very deep S waves and not very tall R waves. But there's something that's abnormal, and you might not be able to see it, but usually there's not this ST depression. And if you see this ST depression, these are like U waves, where you should have a T wave, you've actually got a dip instead of a peak. And this is a child who's got severe hypokalemia. The potassium was 1.6 in this child. And so this was a child who presented in heart failure. And part of the reason was because she was on so much in the way of diuretic therapy that her potassium went very low, and she got this arrhythmia because of that, and poor myocardial function because of that. So if you need to correct potassium, if the potassium's just a bit low, we can give oral potassium. And I won't go through how to correct it in detail, but usually we can give just oral potassium, and you can look up the maximum dose, but it's about 1 millimole per kilogram if the child's under the age of 5 years, and usually half to 1 millimole per kilogram if the child's over 5 years, usually a little bit less. The maximum dose is 2 to 3 millimoles per kilogram. So therefore you can give some potassium twice a day or 3 times a day. And a SPAN-K tablet is 600 milligrams of potassium, or 8 millimoles. And so you can work it out from that. If you think about a SPAN-K tablet as being 8 millimoles, and you can give for a child under 5 years, 1 millimole per kilogram twice a day, that's okay. So if they're like a 20 kilo child, they can easily have 10 millimoles twice a day, or 8 millimoles twice a day. That's 1 SPAN-K tablet twice a day. A 20 kilo 6-year-old would be able to have that. So that's how you'd correct it if the potassium's a bit low, not very low. If the potassium is very low, then you need to give some intravenous potassium. And we've talked about this before in the talk about electrolytes, but how to give potassium safely and how much you can put in a litre of fluid. And I'll just go through it again, perhaps, that when we give potassium, it comes in vials, and a 1 gram vial is 13.4 millimoles of potassium. And we can usually give 1 millimole per kilogram over 4 hours, right? So that's 1/4 of a millimole per kilogram per hour maximum. So if we put 2 grams of potassium chloride in a litre of fluid and run it at normal maintenance rates, like 4 mils per kilo per hour, then we're giving a safe amount, right? We're giving less than the maximum amount. Even if we put 4 grams in, if the potassium is very low, like if it's less than 2, like this child I mentioned before, we had to put 4 grams of potassium in a litre of fluid and run it at 4 millimoles per 4 mils per kilo per hour. And even that was enough to replace her fluid safely. So you can't put more than 4 grams in 1 litre, and you can put anywhere between 2 and 4 grams, depending on the level of potassium. I also think it's useful to make, if potassium's low, then usually magnesium will be low, especially if the patient's on furosemide and you need to replace the magnesium as well. And you can do that either orally or you can give it intravenously. If you give magnesium intravenously, then do it slowly, because sometimes it causes vasodilatation and hypotension. All right, so these are a bit of some fine details about how you correct the electrolyte imbalances in children who have heart failure. It's very common to have to do all of this if a child presents in heart failure. They'll not just pay attention to giving them diuretics and doing that, but also lowering their fever, correcting their anemia, checking their electrolytes, fixing that up. So there's all of these things to consider. When we're monitoring children with heart failure, then it's monitoring all the things we've talked about. So in the acute stage, we should use a monitoring chart like I've shown you before, because that helps us understand whether the child is improving or deteriorating, whether they're in the danger zone or out of the danger zone. You need to monitor their edema, their peripheral edema. Each day you should monitor their facial, their limb edema, how big their liver is. Monitor their lung edema, right? Their degree of respiratory distress, whether they've got crackles or effusions, what their oxygen requirement is, what their saturation is. All of those things tell us about how their lung edema is progressing or improving. And then monitor for signs of inadequate output. So their pulse volume, their limb temperature, their blood pressure, their peripheral perfusion, the urine output, whether they've got a rising creatinine and their mental state. All of those things can tell us how their heart function is going. And in the medium and long term, then think about whether the child's thriving or the older child is losing weight or what their body mass index is. So these are things you can monitor for children who have heart failure, no matter what the underlying cause is. There are some laboratory things you can check for in children with heart failure, but I think nothing is as good as clinical monitoring of children with heart failure. So all of these other things, of course, you can repeat their chest x-ray and see if their cardiomegaly is getting worse or getting better, or their congestion is getting better. But usually you see it clinically before their x-ray gets better anyway. You can monitor their urine creatinine, but you can also monitor their urine output. So clinical monitoring is the most important thing. And some of these other measures, measuring their blood lactate or their acid base or their venous saturation or even an echo, they're all useful. But I actually think the clinical monitoring that I've just mentioned, all of these things, doing it regularly and recording it regularly, is the most important way we can monitor children with heart failure and know whether or not the treatment we're giving is making a difference. So I wanted to stop there because in the last 2 weeks, we've talked about heart failure in children, mostly acyanotic heart disease. And we've talked about large left to right shunts like ASDs, VSDs, PDAs. We've talked about the newborn baby who collapses, and that could be, as I said, at 5 days or 5 weeks of age. The baby who was well at birth but then collapses sometime days or weeks later, and what the differential diagnosis, both cardiac and non-cardiac, is of that child. And then we've talked about heart failure in the previously well older child, like the 12-year-old I mentioned, but it could be a 5-year-old or an 8-year-old who gets acute rheumatic fever, or a 14-year-old who gets viral myocarditis, or a 6-year-old who has a tachyarrhythmia, the main thing is to recognize that clinical syndrome of heart failure in the previously well older child. So there in terms of pediatric cardiology and heart failure, I hope that's made sense to you. I'm going to stop sharing my screen now, and I'm happy to answer any questions that you might have if you